Pacemaker lead thrombus, right atrial thrombectomy. The International Accreditation Commission guidelines make sure that as sonographers, our job is done well. Their impact guides the content of a study, guides what you have to do to assess proper use of diagnostic ultrasound, make sure that machines are safe, provides sample documents on who and what to assess, ensures that sonographers continue their education, and certifies that a sonographer is qualified to do an echo. Collaborative healthcare acknowledges the expertise and contribution of all members of the healthcare team. Patients benefit most when partnerships are built across departments and specialties at the full scope and standards of healthcare. In this case, the sonographer, anesthesiologist, cardiologist, invasive cardiology technicians, nurses, and doctors all worked collaboratively to accurately diagnose and surgically repair this patient's heart condition. A good leader has many qualities, such as being a clear communicator, setting a good example, having integrity, focusing on their team, giving recognition, encouragement, support, and setting goals. The team at Sentara Norfolk General Heart Hospital has many great leaders that embody these traits. They work together in both the echo lab and the surgical setting to give great quality service. This patient sonographer followed the American Society of Echocardiography guidelines for the performance of the study. The original indication for the transthoracic echo fell within the appropriate use for the technology. Additionally, there was appropriate indication for employing a transesophageal echo. The protocol to view the thrombus in multiple views and in multiple planes was accomplished. Color flow and spectral Doppler were used to interrogate the thrombus. Despite dramatic technical improvements, implantation of cardiac devices is still associated with occasional complications. One of these complications is intracardiac clots forming on the device lead. Pulmonary embolism has been recognized to occur in association with PMLT. In our patient, this thrombus necessitated surgical removal since she had been on heparin as a blood thinner. To be compliant with legal and ethical issues, the patient's name and identifying information was removed prior to this case study. All of her information was safeguarded in all reports, echo pictures, and when discussing the case with fellow sonographers. Permission was obtained before procuring any and all information. The sonographer must be educationally prepared and clinically competent. Their scope of practice is wide, ranging from taking patient history into account, monitoring the patient's mental health, working with the patient for optimal results, following protocols for a good study, and putting forth a comprehensive report for the physician to evaluate. One aspect that a sonographer cannot do is inform the patient of what they see while performing the exam. Our patient had questions why she was receiving serial echoes, both TTE and TEE. It is never within our scope of practice for a sonographer to answer this question. The patient was a 79-year-old white female, 129 pounds, 62 inches tall, with a blood pressure of 134/50 and a heart rate of 50 beats per minute. She had reported a fever, fatigue, and shortness of breath. The illness which prompted hospitalization was that she was pale, severely fatigued, and had a fever of 103 and was experiencing syncope. Her physical exam showed that she was agitated and depressed with her current situation, but otherwise without any other physical presentation of illness. Her family history included her father dying of a myocardial infarction at the age of 65, and her mother dying of natural causes at the age of 82. Her children were still living, and there was no mention of any health issues. Her pertinent medical surgical history included a permanent pacemaker put in at the age of 70 due to her inability to pharmaceutically control atrial fibrillation. Her medication included doftalide for AFib, antidepressant, and heparin. Her risk factors for CAD was a 40-pack-a-year smoker for 15 years, postmenopausal without hormone replacement, and a lack of physical exercise. Prior to her pacemaker, the patient suffered from persistent atrial fibrillations. This means the heart rate can vary, and it depends on how many atrial impulses are transmitted from the atria to the ventricles. Here we see that the P waves are replaced by fibrillary waves. Syncope and lightheadedness were the indication for her initial echo. Further indication for the TEE was bacteremia due to a positive blood cultures. Both of these indications are considered appropriate reasons to employ echocardiography. The cardiologist's report said that the TEE and the TEE findings showed severe left ventricular dysfunction and global hypokinesis. A large thrombus measuring 3.3 centimeters by 4.2 centimeters was attached to the pacemaker lead and crossing the tricuspid valve with each cardiac cycle, causing obstruction to flow. The peak velocity across the valve was 1.6 meters per second with moderate to severe tricuspid regurgitation. Her first echo was a transthoracic echo that provided suboptimal images. You can see here the large intracardiac mass in the right heart. This validates the indication for echo. Here we see a video of the mass moving with each cardiac pump into the ventricle. This short color loop illustrates the turbulent flow through the tricuspid valve. Labs were run to see if the thrombus was due to bacteria. The high values of white blood cells determined that an infection helped cause the thrombus. No urinalysis was completed. The patient was taken for a CT scan to analyze if there were embolisms from the thrombus. This test just showed one large thrombus in her atria. Multimodality test confirmed those echo results. Her second echo was a transesophageal echo. Here we see that in this view the thrombus measures almost 4.2 by 3.3 centimeters. This TEE loop illustrates just how much the thrombus is occupying the right atria. This short loop is a color flow comparison of the turbulent flow in the right heart. Her third visit was another transthoracic echo, taken approximately 2 weeks later to determine if there was any change in the mass. These pictures are overgained, but much more clearly show the size and motion of the thrombus. And in this color Doppler, we can see how damaged the tricuspid valve is from the constant abrasion. X-plane was used to get a more robust idea of the size of the thrombus prior to surgical removal. To properly diagnose an intracardiac mass as a thrombus, there must be excellent image quality, identification in more than one acoustic window, and knowledge of normal structures, normal variants, and post-operative changes. The pros of using echo is that it can provide both anatomic and physiologic information about the mass. It's non-invasive and relatively inexpensive, and serial studies are feasible. The cons consist of suboptimal image quality in some patients, relatively narrow field of view, and having to know whether it's a mass or an ultrasound artifact or a mass versus a normal structure. The procedure consisted of removing the thrombus and the pacemaker lead from the right side of the heart. This was done via the subclavian approach. A specialized sheath was placed in the vein, and this was threaded over the lead and guided to the tip, where it attached to the heart. The pacemaker wire was removed along with the thrombus. The procedure uses intraoperative transesophageal echocardiography during the surgical removal. Prior to the removal of the thrombus. And here is the color Doppler over the loop. These pictures were taken immediately after the lead was removed. The patient had been on anticoagulant drugs and therefore was decided that she needed to go surgical removal of the thrombus. Some patients have post-operative fevers and septic episodes which may be related to the embolization of vegetation fragments. A new pacemaker cannot be implanted until the underlying infection is treated. So after the device was removed, the patient was prescribed oral antibiotics for about 10 to 14 days. Upon discharge, she was advised close follow-up with her physicians to monitor her blood work and heart rhythm. The patient will continue to come in for routine echo examinations to monitor her heart. Future tests will help determine if she will require a tricuspid valve replacement due to the damage from the thrombus. The prognosis is good as she recovered nicely from the procedure, and a future surgery to replace the device will be scheduled. She continues her medical regimen of anticoagulants and AFib medication. There are some big innovation trends in cardiac ultrasound, including the launch of the first premium all-touchscreen ultrasound system, the introduction of artificial intelligence to speed, simplify, and make cardiac echo more reproducible, and a big advancement in image quality, approaching that of CT scans. The further we are able to improve visualization within the heart, the easier it will be to distinguish intracardiac masses from normal structures and variants. A new trend for PMLT is percutaneous vacuum-assisted thrombectomy. This is a minimally invasive method of removing large vegetations and is ideal for patients who are not good candidates for cardiopulmonary bypass. I chose this patient because I had to focus on professionalism. Seeing such a large thrombus made me work on my poker face, and I had to have tact and follow the sonographer's scope of practice when answering her questions about her prognosis. I'm glad that she made a full recovery, and I am very lucky that I got to see this procedure.